Hi, I am Dr. Felice Gersh, and for this particular presentation, I'm putting on my OBGYN hat because I am not just a prescriber of hormones, I am a board-certified OBGYN, G for gynecology. So I'm going to talk today about a very common gynecological problem, but guess what? Don't be surprised, hormones get into the act, as they always do, because hormones are part of everything female. So what we're going to talk about is an incredibly common problem called stress urinary incontinence, sometimes just called stress incontinence. Now, incontinence means the unplanned, unwanted loss of urine. So before I get into stress urinary incontinence, and I'm going to also touch on urinary incontinence called urge incontinence, because you have to know the difference. But I'm going to talk more in depth about urge incontinence another time. So basically, there are two types of incontinence that women experience most commonly. And there's another type I'm not going to get into. We'll call that overflow. That would be a neurogenic bladder. Sometimes that happens in women who've had spinal cord injuries or a neurological disease like multiple sclerosis, where the bladder muscles are not functioning well because it's a neurological problem. But we're going to touch on that maybe another day, not today, but just so that you know that's another typical problem, but not anywhere near so common as stress urinary incontinence. Now, urge incontinence is where you lose urine because you just can't hold it. You feel the urge to void, but you can't get to the bathroom in time. It just like, I have to go, poof, it just comes out, usually losing like the entire bladder full of urine. That's urge incontinence. And like I said, we're going to talk about that another time. Stress urinary incontinence is when you feel nothing. You just get up. It could be as simple as get out of a chair. You step off a curb. It could be a little bit more activity, like you're jumping up and down on a trampoline, or you're playing tennis or some other sport, or you're just running, or you're laughing or coughing, and urine just comes out of your bladder and you don't feel it coming. You have no sense of having to go to the bathroom. You just get wet. It's very distressing, and urine has a smell and it's all wet. It can really be amazingly disruptive to quality of life. So we don't want to underestimate the seriousness of this problem as far as a quality of life issue. Now, women don't die from stress incontinence, but it's really, you cannot underestimate the impact it has. And it's a big industry dealing with this particular medical problem. It is so common. How common is it? Well, in premenopausal women, about 10 to 15% will experience this unplanned, unwanted, completely unpreventable at that point loss of urine. By the way, in terms of the amount, it could be anywhere from a few drops to the entire bladder full. It could just soak right through a woman's clothing. So it can be variable in terms of how much comes out. Of course, there's some correlation with how much is in the bladder. So it can be, completely disruptive if a woman gets completely wet with urine and she's like out having fun, she's laughing, and suddenly all her clothes are wet. And of course, it can go right through the clothing onto the fabric below, onto the floor. I mean, it's just terrible. So we have that particular problem. And so I mentioned that 10 to 15% of premenopausal women have it. What about after menopause? The rates dramatically rise. After menopause, up until around the age of 65, around a third of women have some degree of stress urinary incontinence. A third. After age 65, it's half of women will have this problem. That's why it's a big business trying to deal with it. One of the ways that it's dealt with is with collecting the urine, trying to have protection. So the adult diaper industry is a huge industry. As you know, you can buy diapers for babies. You can also buy diapers for adults. And the biggest market is women. Men can have incontinence too, usually when they've had prostate surgery or prostate cancer, but we're not going to talk about men. But the biggest market for protection, like massive diaper industry and so on, is for women. Of course, some women just buy pads, and then some women buy panties that can now absorb menstrual blood or urine up to a point. So that's another new big industry. Now, who is experiencing this problem? It's not 100% of women. Most of the women have had deliveries, usually vaginal, but doesn't have to be. It could have been from having had a C-section, because when you have a baby inside of you, the head will go down into the pelvis and put a lot of pressure and can cause some stretching. Now, when you have a vaginal delivery, sometimes there's actual tissue damage to the pelvic floor. So first you set the stage by having a vaginal delivery, usually, or a pregnancy. Now, the more deliveries you have, the more trauma there will be to the pelvic floor and the vaginal canal. If you've had a very large baby, then you can have more damage. If so, multiple deliveries, or very large babies, or an instrumented delivery, like say someone uses forceps and there's a traumatic delivery, that can also add injury. So what we're talking about is tissue damage, and we're talking about also the sphincter. So if you know this, if not, I'm telling you, after menopause, women have more of an incidence compared to prior to menopause, and also more than men after menopause, of acid reflux, GERD. That's because there's a change in the motility, but also the sphincter. Estradiol and progesterone are critical for maintaining tissue integrity. The collagen, the structure of tissue, is really controlled in large measure by estrogen. Estradiol, the estrogen produced by the ovaries, and to some degree progesterone, but much more estradiol. After menopause, of course, there is no more production of estradiol, and all the connective tissue, the supporting tissues, start to degrade. Not just like you have more wrinkles in your face that people, of course, notice, or in your hands, but in areas that you don't see, like the sphincter that is necessary to create a closure between the bladder that holds the urine and the urethra where the urine comes out. And that sphincter needs to be tight, just like if someone has the sphincter between the esophagus and the stomach, and that becomes kind of loose, then the food and contents in the stomach can come up into the esophagus, gastroesophageal reflux. And when you have poor tissue, you can have prolapse of the tissues in the vagina, like the bladder can actually start dropping. It's like a hernia of the bladder into the vaginal canal. And the rectum can also become more herniated or start also entering into the vaginal canal. The uterus can start dropping. That's called uterine prolapse. So you can have descensus of the uterus dropping. You can have a cystocele bulging of the bladder into the vagina, or a rectocele bulging of the rectum into the vagina. And all of this can change the orientation of the tissues. So that can also cause a dropping of the urethra that can cause more of a funneling. So if you have some dropping of the tissues, and this happens when you don't have proper tissue integrity, when you lose your estradiol. So you have these tissues that are no longer very strong, you have these organs that are protruding and dropping, and the sphincter, the muscle that controls the closure of the bladder entering the urine into the urethra, that sphincter is no longer strong and tight, and all this stuff is drooping. You can have what's like a funneling. So you know how a funnel works. And if you no longer have the proper alignment, so you have a lax sphincter and everything is kind of drooping down, the urine just can flow like downhill right out the bladder and into the urethra and then out of the body. creating a wet mess. And if you add some intra-abdominal pressure, so you're putting a little bit of pressure around the bladder, it just pushes it out because there's nothing to stop it. The sphincter doesn't close properly and things are droopy, so it just flows out. So you don't want to have any of that happening, of course, because that, like I said, is a huge problem, changes the quality of life. So when you add that little pressure, so like I said, say you're jumping up and down, that's adding pressure around the bladder. If you laugh or you cough, that's creating pressure. If you have chronic constipation and you're always pushing out your stool, that is obviously creating pressure all over, including around the bladder. And over time, that can weaken the supportive muscles. So chronic constipation just adds like injury to the problem, and you then have even a worse problem. If you have smoking and you have coughing because you have a smoker's cough, of course, that is also a problem. And smoking is so bad for tissue integrity, that is another added problem. Another interesting risk factor is obesity. I mean, what isn't it a risk factor for? They have found that loss of weight, loss of excessive body fat, can actually have a very significant benefit on having this problem of stress incontinence. So excess weight loss is very beneficial in so many ways, including improving continence. So you don't have this horrible leakage when you do normal things like talking, laughing, walking off a curb, and so on, getting out of a chair when it gets really bad. So what else can we do? This problem is incredibly common. Loss of estrogen production plus trauma from, most commonly, from having babies combines to create this problem. Sometimes it could be other things, like if someone had radiation therapy because of a pelvic cancer, if they've had pelvic surgery, things of that sort. So there are other things that can contribute to damage to nerves and to the tissue integrity, but the vast majority of cases are related to pregnancy and menopause. So we can't stop having babies when we want them. That's part of what we want. Most of us want to have babies at some point in our life, and that is a price to be considered, but most of us will never consider that. By the way, this idea that was really popular for a while of, well, let's try to lower the risk by having a C-section, very bad idea. C-sections have a bad influence on baby's microbiome, and women lose a lot more blood when they have it, and women can have stress incontinence even when they've had a C-section, because that big baby head pushing down into the pelvis can also change a lot of different things in the pelvis, not just having the vaginal delivery. So please don't think that having a C-section for no reason. Now, when you need a C-section, it's life-saving for baby and mom. Could be either or both. That's a different story, but not just because you're trying to prevent this problem. There are much better ways. For example, having vaginal estrogen. And the one that I would recommend is estriol, but that's a compounded estrogen. The reason that's very helpful is that the receptors that are activated are beta, and there's actually published data showing estriol may be a little bit better than estradiol, but you have to pay significant money getting from a compounded pharmacy. Not everybody can get a doctor to even prescribe it. So it's okay to use vaginal estradiol. It comes as a cream or a ring or suppositories. And I usually use the cream, but these other forms are also good. And you use it to maintain the tissue integrity. You want to start it early in the perimenopausal years. You want to start it before you get vaginal dryness, because then you've already had some loss of tissue integrity. Early is best. So I love systemic estrogen because I want to help every system in the body to be optimized. But if we're just talking about the incontinence issue, that's part of the genitourinary syndrome of the menopause, is stress incontinence. vaginal estrogen as estradiol, the most common form, is very, very beneficial because that's what estradiol does. It maintains the health of all aspects of connective tissue, the collagen, the fat, the bonding between the different cells, all the different aspects of tissue integrity is helped by having estradiol on board. Now, what else can we do? Well, there's a whole new array of specialists called pelvic floor physical therapists, and they do all kinds of things to help improve the structure and function of the pelvic floor girdle, the pelvic floor muscles. When I say structure, they actually help exercise the pelvic floor. Those muscles, by improving their health and their strength, you can actually improve and reduce stress incontinence. So I use pelvic floor physical therapy as a tool all the time with my patients. There are many of them that develop stress incontinence, usually because nobody told them before they came to see me that estradiol is really helpful to prevent this problem in the first place. Now, pelvic floor physical therapy is wonderful. They teach exercises, and some of these you would be taught, and some of these you can learn on your own, like Kegel exercises, where you would try to, without being on the toilet, you just pull in those muscles and tighten them like you were trying to prevent urinating. And then you would hold them, and you would start with just a few seconds and work your way up to 10 seconds. And you would want to be able to hold that tightness, that contraction of the pelvic floor for 10 seconds. And you want to work your way up to doing 10 repetitions 3 times a day. But if you can't hold it for 10 seconds, hold it for 3 seconds, whatever you can do. And you'll get better as you practice, like all issues with muscle strength and control of your fitness. Pelvic floor fitness takes time and work. So that's the goal, though. You want to do repetitions about 10 times, 3 times a day. Not when you're actually emptying your bladder, in between. But it's really good to work with a pelvic floor physical therapist to begin with, because they can be sure you're doing it correctly, and sometimes they vary it. So it's sometimes good not to just hold it, but to go in and out, like you're going like this with it, so that you're not just tightening, tight, and then relax, and then tight, but sometimes to do variations. So that's why I love working with pelvic floor physical therapists. There are also electrical Stim devices that can be ordered or purchased that are inserted into the vagina. They put out a little electrical signal that causes essentially a contraction of the pelvic floor muscles. So it creates that contraction. And these are designed for both stress and urge incontinence. So you put it on the right setting for stress incontinence, because that's what we're dealing with today, and it will help. In fact, in Europe, that is the #1 treatment, are using these little intravaginal electrical Stim devices. And most of them now are cordless, right? And you would only put them in for maybe 15 minutes a day. Some you may do twice a day, once a day, but you can put it in and just watch television. It does the work for you. It creates the little stimulation that causes the contraction. Another device that can be used, but this requires a doctor like me to fit it, is a pessary. A pessary is like a round device made out of a silastic material. It's flexible. It's kind of stiff, but it's still flexible. You can bend it. Sort of like in the middle, and it has a little bulb. So it's like a little circle, and at the end there's like a bulb, okay? And that is fitted under the urethra. So it goes into the vagina, and that little firm bulb sits under the urethra, and what does it do? It pushes it up. It puts a little pressure on it, pushes it up, so it doesn't sink down, droop down, and create that funneling effect. So you just push it up. So, if the fluid, the urine, is flowing downhill, and then you have the urethra and it's pushed up, well, the urine would have to go up and then down, so it often will just stop there. So it stays in the bladder instead of coming out. So this is not used anywhere near enough, because I can teach my patients how to put it in, how to take it out. If they don't want to, if they're not sexually active, I can put it in and just take it out and clean it once every 90 days, and they will have pretty good results so that they don't have to leak a lot. Maybe a tiny bit, but not much. Like a pad can take care of it. They're not going to have to worry about changing their clothes and being embarrassed and that type of thing. So a pessary is a very underutilized device. What else? Bulking agents. So this would be injected typically by a urologist or a urogynecologist. So these are specialists in this area. And they can inject a bulking agent kind of like dermal filler. You know how people get fillers in their lips and then they get big lips or they get bigger cheeks? So it's a dermal type of filler. It's a bulking agent, and it's injected around the sphincter area to bulk it up, to try to keep the sphincter more closed. So it's not so lax, so loose, so that it will be harder for the urine to flow out. But you can still get it out. It's not, you don't want to block it, then you can't get any urine out of your bladder. But enough so that it narrows it, so it's not like loose and gaping, okay? So they do similar things actually for hiatal hernias, right? They put things around and sort of snug it up so that the sphincter is not very good. It's kind of loose, so they snug it up. So they do a similar thing by putting this bulking material around the sphincter area of the urethra, which is the exit from the bladder into the urethra, and that sphincter that keeps it closed when you don't want to be urinating. That is something that should be relaxed when you're ready to relax it and have the urine come out intentionally, not unintentionally. There's surgeries that also can be beneficial. And back in the heyday when I did lots and lots of surgeries, I did many of these surgeries because sometimes that's really the way that the patients wanted to go, because these surgeries can be very successful. The one that I did was a TOT, a transobturator tape. The other type, which is also very popular, is a TVT, tension-free vaginal tape. So it's a TOT or a TVT. A TOT, you would put the puncture in the groin area, and then you put a little ribbon tape, and it slips under the urethra and then out the other side. So it creates a sling, kind of holds up that urethra. Okay, so it's not sagging down, creating that funneling effect. A TVT, the punctures for this tape, a similar tape, like a little ribbony tape, comes at the pubic area, sort of like the pubic bone at the top area, kind of like the top where a bikini would lie, if you were wearing the top of a bikini, and the two little punctures up there, and then the tape slips under the urethra. So it's either coming out laterally from the groin or from the top area, like where a bikini line would be, and then down and up. And they are called sling procedures. They lift up and support the urethra, once again, so that you don't have that just funneling down, so that the urine, if it's coming out of the bladder, has to go uphill before it goes downhill. And by going uphill, hopefully it won't then go downhill and come all the way out, wetting the clothing. So there is so much we can do to both prevent and to treat stress urinary incontinence, a problem that affects ultimately half of women. It's a huge industry. Many doctors, this is their entire career, is doing these surgical procedures. Now, I had mentioned prolapse surgery. Now, some women do not have stress incontinence until they have prolapse surgery repair, because when the uterus is pulling down, like it's drooping down and the bladder is drooping down, the urethra is kind of like in a kink kind of position, so that dropping of the organs actually prevents stress incontinence. And then when you put the organs back where they belong and you lift them up, then suddenly the funneling occurs, and then suddenly the woman starts having stress incontinence, which she didn't have before. So many times when this surgery is performed and you're dealing with prolapse, cystocele, rectocele, they will prophylactically put in one of these slings so that the woman doesn't have to go back and have another surgery because now she has stress incontinence. Now, sometimes there's a problem where the stress is actually masking something that's actually a bladder spasm. So before surgery, many urologists or urogynecologists will do a study in the office called a urodynamic study, which actually is looking for bladder contractions and how much volume the bladder can hold, so that you don't want to have other things going on like what we call mixed incontinence, where you also have a problem with a bladder spasm contributing. And if you put, just as another note, if you put in a sling, either the TVT or a TOT, and you make it too tight, then what can happen is that you actually create obstruction, and then people can't void, and they have bladder residual. They can't empty their bladder properly. So that's why they call it tension-free. There always should be a little space between the urethra, if this is like the urethra, and underneath the tape, so that it's not really tight. There should be a little space. Like when I did, I would always make sure I could put a little pickups in there, and just there's a little space because it's tension free. If you put it too tight and you pull up too tight, then the person can't empty their bladder at all. That would be obviously horrific. And when that happens, somebody has to go back in and take out the tape, which of course then the whole surgery was done for nothing. As well, if there's a question of a neurological problem like multiple sclerosis or a spinal cord injury, you would want to make sure that it's not overflow leakage, where the bladder doesn't have normal function of its bladder muscles, and so it just fills, and then it has overflow. It just gets so full that the urine just comes out. That's a different problem, as I mentioned. But if there's a question of something like that before doing any kind of surgery or even other evaluation, you'd want to make sure this isn't a neurological problem, a neurogenic bladder. So I don't want you to feel like, oh, this is so complex. It isn't. There's just a variety of treatments that are wonderful. Now, there's one drug. Duloxetine is a pharmaceutical that the brand name is Cymbalta. Okay, so this is what we call an SRI, SNRI, or an SSRI. So it works with norepinephrine and serotonin reuptake. And it turns out that this drug can, in some people, be successful for stress incontinence by increasing the tone, like the muscle around the sphincter, to work better. But once again, it's a pharmaceutical that has a variety of potential side effects. But, you know, it is, I need to tell you, it is a drug that for some people can be beneficial. So like I said, the brand name is Cymbalta. So these are lots of different things available for treating and preventing. So prevention is my forte. I love prevention. So the best way to prevent it is start doing your Kegels and your exercises, maintaining a good, healthy musculature of the pelvic floor after you have a baby. In fact, this is now getting more and more common, that after a woman has a baby, she's referred for pelvic floor physical therapy. So she rebuilds the power and strength of those pelvic floor muscles right out the gate after having a baby. And then when you're entering into menopause, in perimenopause, get on at least vaginal estradiol or estriol and maintain the health of those tissues with estrogen, because that is so essential to maintain the tissue integrity. And do not have a C-section trying to avoid this problem, because that is not the way to go. So stress urinary incontinence can be prevented in most cases when acted on early, and there is great treatment so that no woman has to live in diapers.